we're good.
Okay, good.
Okay, got it. So that did the trick. That's bizarre. Thanks, Beth.
Okay, why don't we'll wait 1 minute and then we'll get started.
That's not what you guys want to look at.
Hmm. Okay, we've got some people signing on, so I think we'll get started and make sure we use everybody's time well. Good afternoon, everyone. Thank you very much for joining. My name is Amy Rosenstein, and I'm the Administrative Director for MCPAP for Moms, and this is our quarterly webinar. Today's topic is when to call MCPAP for Moms and we'll be talking about 4 high-yield cases. Just a little bit of housekeeping before we get into the presentation. The session is being recorded and it's going to be available on the MCPAP for Moms website at www.mcpapformoms.org. A copy of the PowerPoint slides will also be on the website on the tool and resources page under the PowerPoint presentations. We are asking that if you have questions, please put them into the chat box and we'll either answer them during the presentation if it's something pressing, or otherwise there'll be time for questions and answers at the end of the session. And then I just want to let you know that at the end of the session presentation, you'll get a very brief survey, and we really appreciate if you take the time to fill it out. So today the presenter is Dr. Aruj Kamal Haider, who is the medical director of MCPAP for Moms. She is also the medical director of the Women's Mental Health Clinical Service at UMass, and also the assistant professor of psychiatry and obstetrics and gynecology at UMass Chan Medical School and UMass Memorial. She's also a consulting psychiatrist at the UMass Lifeline for Families, and she really enjoys giving state and national talks on perinatal psychiatry access program impact and important women's mental health clinical topics. Dr. Haider also serves as the medical student clerkship director for the Women's Mental Health Elective in the Department of Psychiatry, and has received numerous awards in training education. Her particular clinical expertise is in caregiving support and sleep, perinatal OCD, and psychosis. So again, please submit your questions in the chat and we will make sure we get to them at the end of the session. So with that, I am going to turn it over to you, Dr. Haider.
Thank you, Amy. Hi, everyone. Thanks for being here today. So I'll jump right in. Today, we'll be discussing the evidence for high-yield cases with a focus on SSRIs. Next slide, please. All right, so the overview for today, first we'll talk about 4 high-yield clinical cases. Then we'll go into some basics of SSRIs in the perinatal period, perinatal depression, perinatal anxiety, and then we'll talk about an overview of MCPAP for Moms, what the program is, how it's structured, and how we can help you during your phone consultations or any other questions you may have about perinatal mental health. Next slide, please. So case number 1. This is a classic MCPAP for Moms phone consultation. A 22-year-old G3P2 at 20 weeks gestational age presents with reporting symptoms of depression. Her EPDS was not done and her bipolar disorder screen was not able to be done. The patient has no psychiatric treatment or therapy in place. So the OB calls MCPAP for Moms for a phone consultation and asked to speak to one of our psychiatric consultants for assistance. When I talked to her, she says, well, first I asked the OB some clinical questions pertinent to this case, the EPDS score, et cetera. And the provider says, I'm just feeling really overwhelmed and I'm just not sure what to do. I'm really just looking for your guidance. Great. So we're happy to help. And this is a classic case where we get quite a few of these. And I'm going to go through it in terms of the resources I could offer, the high-level consultation, and then follow-up steps in terms of helping this patient specifically. Next slide, please. So how can MCPAP for Moms help? So the goal of these consultations is really to meet you where you're at when you call and to give you high level recommendations with the limited time that you all have, because we know you're all busy frontline providers. We all know that at MCPAP for Moms. And during these consultations, we aim to disseminate accurate evidence-based recommendations while we talk to you about your cases. And I think the take home points of this specific case and any case that discusses SSRIs is that untreated depression has major, major risks, including suicide. So we can and we should use SSRIs when they are clinically indicated. And typically, the benefits of the SSRIs are going to outweigh the risks. And to quote Dr. Stephen Fleischman, the president of ACOG, American College of Obstetrics and Gynecology, he recently said, for pregnant people who need SSRIs, they are life-changing and life-saving, and could not agree with that more. So during this phone consultation with this obstetric provider, I talked about the role of MCPAP for Moms during the consultative process. We talked through the best SSRI for her patient. We do not prescribe at MCPAP for Moms. We build the capacity of frontline providers and kind of teach them how to fish and teach them how to prescribe, so then they can go on with the information they've learned during our phone consultations, which is really a clinical case and an education opportunity, and treat many and many other patients that they may treat in similar ways. So I told this OB, we don't prescribe, but I can tell you how to prescribe this SSRI. I can talk about the evidence base of SSRIs in pregnancy, postpartum, preconception period. And you can call back at any point with more questions. You can call back once a day, you can call back once a week, at any point. And so that was the bulk of what she and I had discussed. And during the consultation, we also discussed that while validated screening instruments were not able to be done with this patient, we talked about generally when screening instruments should be done in the perinatal, during pregnancy, according to ACOG and the AIM bundled and standardized guidelines. We did discuss that this patient has done well on an SSRI in the past, and we discussed the symptoms of patients struggling with perinatal depression, what that clinical picture looks like. We talked about the signs and symptoms of hypomania, mania, and florid psychosis, because we do know that unopposed antidepressant treatment, if someone has a history of bipolar disorder, can precipitate mania or hypomania or potentially postpartum perinatal psychosis. And the ACOGs and the AIM perinatal mental health bundles talk about this, and they were released for the first time June of 2023, and they discuss the importance of screening during pregnancy with an MDQ, a mood disorder questionnaire, because of that rare but potential side effect of postpartum psychosis, or inadvertently putting someone into mania if you give them SSRIs and they in fact have a history of bipolar disorder. So this is something that ACOG emphasizes well. So the provider, after this consultation, she was grateful. She noted that she'll prescribe the escitalopram after the phone consultation, since the patient had responded well to it in the past. Next slide, please. And our research and referral specialist found this particular patient a psychiatric prescriber, and this OB was happy to bridge long-term until the patient's first appointment with that psychiatric prescriber. So perinatal mental, next slide, previous slide, yes, thank you. Previous slide. Perinatal mental health and, thank you, substance use disorders are common, undertreated, and the leading cause of maternal death in the US. So on the left-hand side, we know that 1 in 5 perinatal individuals around the world will suffer from a maternal mental health complication. And on the right, of those who experience symptoms of perinatal depression, about 75% of them go untreated. Only 25% actually end up receiving treatment. So the important thing is, and this is from CDC MMRC report from about 2 years ago, mental health conditions are the underlying cause of 23% of maternal deaths in the US. And studies show that 10 to 20% of women of perinatal individuals in the US really experience significant symptoms of depression while pregnant. And when in other data, when they have gone back to look at that 23%, they have found that almost 100% of those of that data of those deaths were preventable. Next slide, please. So perinatal depression is the most common complication of pregnancy. It affects as many as 1 in 7 individuals. And the highest risk time for most women for mental health disorders really revolves around the childbearing ages. So, for example, averaging across populations, it's 1 in 7 or 15% of pregnant and postpartum individuals who actually experience perinatal depression. Next slide, please. So 2/3 of perinatal depression actually begins before birth. And this is from Catherine Weisner's study from JAMA Psychiatry in 2013 that we often cite. So 1/3 of the time, the symptoms are occurring for the first time after the baby is born. So 2/3 of the time in pregnancy, 33%, and 27% before pregnancy, that's really when symptoms of perinatal depression are beginning. And perinatal, the word perinatal is defined as from the moment of conception to about a year postpartum. So that almost spans a full 2-year time span. That's a pretty long time. And at any point, symptoms of depression can occur. We often think about it as postpartum depression occurring only after pregnancy, but that's a misnomer. It really occurs at any point upon conception to a year postpartum. So that's why we call it perinatal depression. And that's why it's so important to engage high risk individuals or any individual who has symptoms of mental health issues with a mental health provider as early as possible. And so, for example, the reproductive endocrinology and infertility clinics at UMass that I run, the mental health component, doing IVF is really a great time to give a screening instrument and to talk about someone's mood, to ask them, so how are you doing? I know you're planning IVF and this is just the beginning of the process, but I do think IVF and that time period preconception is a great opportunity to connect potentially at-risk perinatal individuals to a mental health provider. So just wanted to share that clinical caveat. Next slide, please. So past depression is the #1 risk factor for perinatal depression. There are reproductive related factors and general risk factors. So on the left, personal history of perinatal depression, a family history of perinatal depression, history of mood changes related to hormonal changes like hormonal contraceptives, PMDD/PMS, as we used to know of it. And general risk factors include younger age, higher neuroticism, childhood trauma, sexual abuse, psychosocial stress, domestic violence, chronic medical condition, and race. Next slide, please. No choice is completely free of risk. We need to balance and discuss the risks and benefits of medication treatment and the risks of untreated mental illness. So I think if there are 2 slides that I want to emphasize from this entire slide deck, it's this slide and the next. And so thank you for the questions, and I will be happy to come to them at the end. If anyone has any more questions, please put them in the chat. So we need to balance and discuss the risks and benefits of medication treatment and the risks of untreated mental illness. So several professional societies over the year, American College of Obstetrics and Gynecology, ACOG, American Psychiatric Association, Society for Maternal and Fetal Medicine, consistently state that treatment choices during pregnancy should really be made collaboratively with the healthcare provider, the perinatal care provider, professional, and the patient, using the best available evidence that we know. And the key point is weighing the risks associated with exposure to medication to the risks related to untreated psychiatric illness in the mom. I like to reframe it as a risk discussion instead of risk versus benefit, because it really comes down to the risk of untreated illness versus the risk of psychotropic exposure to the developing fetus. Next slide, please. And we know that untreated perinatal depression has many, many risks in the mom, the fetus, the newborn, developing infant and child, etc. No decision is risk-free. SSRIs are among the best studied class of medications in pregnancies. And this comes from decades and decades long research with thousands and thousands of studies over the years. So we know that untreated perinatal depression is potentially very dangerous, and it can be linked to suicide. It can cause suicide. Perinatal psychiatric illness is associated with significant morbidity and mortality. We know this, and recent studies indicate that suicide is a leading cause of pregnancy-related death in the United States, and these deaths are preventable. So the consequences of untreated depression really goes well, like way beyond that of maternal distress or of maternal suffering. And they are linked to increased rates of preterm birth, low birth weight, small SGA, small for gestational age, attachment bonding issues, and potentially poor neurodevelopmental outcomes for children. And both ACOG and APA really emphasize that treatment, which includes medication, it is not optional. It's essential to the well-being and the health of maternal and infants, and really reducing preventable deaths, as we know. I'll also add that both medication and non-medication options really have to be considered. We talk a lot about meds, but for all my patients, and I know all my colleagues at MCPAP for Moms, we always are encouraging non-medication treatment in addition to or as an alternative to medication. So that includes, but is not limited to, psychotherapy, exercise, nutrition, vitamin D, natural sunshine, yoga. There's some anecdotal positive reports of acupuncture. Some of my patients in the, during pregnancy and postpartum really benefit from, acupuncture, physical therapy. So really non-medication alternatives in addition to medication is always being discussed. Next slide, please. Specifically, what does the data say about SSRIs? So this is what we know. SSRIs are among the longest, best studied class of medications in pregnancy. Both medication and non-medication options should be considered, like I just mentioned. And we always encourage non-medication in addition to or as an alternative to medications. So it comes down to two things. I think it's like the validity, the actual scientific validity, and then the treatment, the necessity of the treatment, the clinical necessity. And when you look through clinical data and all these epidemiological studies over thousands and hundreds of studies over the years, they show of pregnancies over the years, they show that after controlling for potential confounding factors, SSRIs are not associated with major increases in congenital malformations or neurodevelopmental disorders. And like I said, the discussion, in my opinion, really needs to be reframed around the risks of untreated illness. And then there's treatment. So treatment is essential. And those with milder forms of illness may respond to non-pharmacological interventions. Psychotherapy is always being considered, and then exercise, diet, nutrition, etc. But for those with moderate to severe or recurrent depression, it's really non-pharmacological plus medication. It's both of those. And the reason is medication is often for moderate to severe recurrent depression required to maintain stability and to prevent relapse. Next slide, please. So case number 2. So 28-year-old G2P1 at 24 weeks gestational age who has a history of depression and stopped her antidepressant. The midwife calls and tells me that she's extremely concerned about the patient because the patient shared that she had stopped her medication and cannot find a therapist. The patient does not have a psychiatric prescriber, and the midwife calls asking for help. Next slide, please. So when I spoke to this midwife, we talked about MCPAP for Moms and how we helped her in the consultative process. We support any type of provider calling. Anyone can call MCPAP for Moms. If you call, we are not going to turn you away. We only take prescribing related phone consultation calls or do a face-to-face evaluation for a patient if a prescriber calls. We can do a general perinatal mental health phone consultation, but if the question is related to medications or prescribing, our requirement is that it has to be a prescriber, because sometimes the psychiatric consultant in our program may feel that the patient needs to be seen for a one-time face-to-face evaluation. And when and if that happens, after our face-to-face evaluations, prescribers have to prescribe after that, because at MCPAP for Moms, we do not prescribe. And so prescribing related phone consultations have to be taken have to be called in by a prescriber into the program, but anyone can call, and we're happy to help with any sort of general perinatal mental health consultation. So in this case, the MCPAP for Moms consultant, I felt that a face-to-face evaluation was appropriate, and really to talk about a risk assessment discussion, diagnostic assessment, validated screening instruments, pharmacotherapy discussion. And the midwife was happy to actually prescribe long-term after the face-to-face evaluation, and that's what had happened. And the patient, it sounds like, already had a therapist, and the midwife was happy to prescribe the psych meds. So next slide, please. High risk, there is a high risk of relapse during pregnancy in individuals discontinuing antidepressants pre-conception. So we know that when we continue medications, the perinatal individual has a 25% of relapse. If that perinatal individual were to discontinue the antidepressant at any point during pregnancy, there is a high risk of relapse, and that increases to 65% chance of relapse. So that is significant. So we really are encouraging perinatal individuals or patients to stay on antidepressants before, during, after pregnancy, even during delivery, the day after delivery, and long term. If tapering medications prior to conception, continue to follow the patient during pregnancy to ensure that she is stable and in remission. Next slide, please. So no choice is completely free of risk. Yep, we went over that. That's actually a duplicate, so we can go on to the next. So MCPAP for Moms has created an EPDS score-based follow-up guide to help you with this. So this guide will be available in our updated MCPAP for Moms OB Toolkit, January of 2026. And essentially what it is it's a guide to help practices navigate the EPDS. And we encourage you to call at any point during this guide. We're here to help, and we can help you with anything related to safety concern questions, risk assessment, discussing a Section 12 and how to navigate it. What is a Section 12? I want to learn about it, when to send someone to the hospital, etc. While we are not an emergency consultative service, and if there's a true psychiatric emergency, you would need to send the patient to the ER, call 911, crisis, etc. But if it's not a psychiatric emergency, we are, yes, Beth, if we could make that larger, if possible. It may be a little bit blurry, and we can also send that out for those who are interested. At any point you can call, and we're happy to help you during that process. And it's divided between 19 to 30, which usually means moderate to severe depression and the patient would need a medication, and 0 to 18. And it really just goes through the steps. Is there imminent safety concern, non-imminent safety concern? How is that defined? What you would do, and at what point should you call MCPAP for Moms? And it really just goes through that nicely for you. So that's something new that we've created for you all that will be on the website shortly. Next slide, please. So the EPDS score. So just in general, for validated screening instruments, I think it's important to remember that screening instruments are not diagnostic tools. You're not going to diagnose depression by using it in EPDS, but EPDS correlates with just severity, and by the tool, you can identify individuals who have symptoms consistent with mild, moderate, or severe depression or anxiety. And the key thing about the EPDS, it's not just a score on a sheet of paper that's uploaded into the patient's chart and it's just stuck in the EMR. It allows all perinatal care professionals or anyone interfacing with, a perinatal individual to ask them about their mental health, to open that discussion and to get the conversation going. How are you doing today? Because we're all very busy, and oftentimes if we don't have that integrated in our obstetric or primary care workflow, forgetting to ask about mental health is certainly something that can happen. So the Edinburgh Postnatal Depression Scale is a validated depression screening tool for use in pregnancy in the postpartum period. Greater than equal to 10 is a positive screen. It's 10 questions. Number 10 talks about self-harm, self-administered. The anxiety component is numbers 4 and 5. It's validated in perinatal populations and well over 40 languages. And that is also in our MCPAP for Moms toolkit on our website. Next slide, please. And this is the actual EPDS. And then we can go to the next, which talks about scoring. And remember, this is how the patient has been doing in the past 7 days. And I'll just say it's important to score this before the patient leaves the office, because if in fact it is positive, you want to address those symptoms urgently instead of chasing down the patient, after she leaves. Next slide, please. So the PHQ-9 is also a validated depression screening tool for use in pregnancy and the postpartum period. Greater than or equal to 10 is a positive screen. And there are 9 questions. Number 9 talks about self-harm. It's validated in perinatal populations, and it's available in over 100 languages. Next slide. So we want to talk about the same prescribing principles for preconception, pregnancy, and breastfeeding. So we always want to use what has previously worked for the patient. We want to use the most minimal effective dose possible. Always start low and then titrate high as clinically indicated and if appropriate. We really want to minimize switching, and we really want to minimize exposure to the fetus. That is key. Monotherapy is always preferable. We want to go low, we want to go slow, we want to use as minimal amount of medications as possible. We need to be aware of the need to adjust the dose with advancing pregnancy, and we want to discourage stopping SSRIs prior to delivery. So now the next 2 slides, I'm going to talk a little bit about the data of SSRIs, the recent data and what we know about them. So most data of SSRIs in the perinatal population does not support increased risk of birth defects. I'll say data is largely inconsistent for paroxetine, or has been, but it has not been associated with increased risk of cardiovascular defects in the larger studies. And the study cited at the bottom by 2013 is probably one of the more recent larger studies we have that goes into this. So what we do know is that larger studies in the US and Europe really don't show a significant increase in birth defects in babies exposed to SSRIs during pregnancy. So with paroxetine, that's always the one that at MCPAP for Moms we get questions about. Paroxetine use during early during pregnancy has historically been the most controversial, since it was previously in some reports associated with an increased risk of major malformations like atrial and ventricular septal defects. But the assessment of large databases have not supported this finding. So I think that's the key thing. When you really pull it all together, it's reassuring for paroxetine in particular. Next slide, please. So there is possible transient neonatal symptoms with exposure to antidepressants. These are transient and self-limited that may occur in up to 30% of neonates. Data does not support a taper in the 3rd trimester. So I think the key thing with this is this is time limited. The risk may increase with polypharmacy, especially with benzos that we know. And the clinical picture looks like the neonate may be irritable, abnormal crying, maybe a little bit lethargic. There may be a slight tremor. Feedings may be affected or disruptive, and there may be some respiratory distress, but we do know that it is time limited. It does not pose risk or harm to the baby, and it's time limited and usually resolves within days to weeks at the max. And the severity and length of that clinical course is impacted by numerous factors. But this can occur with neonates who had maternal exposure to SSRI use, but it is self-limiting and not detrimental to the baby. Next slide, please. The absolute risk of persistent pulmonary hypertension appears to be very small. So PPHN will often come up with SSRI use, and the risk of persistent pulmonary hypertension associated with late pregnancy exposure to SSRIs, if it's present, it's much smaller than previous data that we know. And so this 2015 article from JAMA goes into that. So if we assume that the estimates of risk from this study are accurate, then what we do know is the absolute risk, which is really what we look at when analyzing data, the absolute risk of persistent pulmonary hypertension is very, very small. While the relative risk is roughly double, the absolute risk remains very small because the baseline risk is low. So most babies exposed to SSRIs, including paroxetine, they don't go on to develop persistent pulmonary hypertension. I think that's important to say, and something that sometimes gets missed when we talked about this medical diagnosis. And I think another key thing is factors like prematurity, cesarean delivery, or maternal smoking on their own also contribute to persistent pulmonary hypertension, sometimes more than the actual medication itself. The baseline rate of 1 to 2 per 1,000 births may increase to 2 to 6 in 1,000 births if you're on an antidepressant during pregnancy. Also a very, very small increase. Next slide, please. So there's a possible association with preterm labor and low birth weight for maternal SSRIs, and depression itself. I think this is the key thing. Untreated depression itself is also a risk factor for preterm labor and low birth weight. So limited studies do not suggest long-term neurobehavioral effects on the children. Untreated perinatal depression is associated with negative neurobehavioral effects on the children. That's something that we see time and time again in the studies. Next slide, please. So there is a small but absolute risk increase in postpartum hemorrhage secondary to SSRI use. There is a slightly increased relative risk of about 1 to 2, but there's a very small absolute risk increase. SSRIs may be associated with a slightly increased relative risk, but many of these studies, and I think this is the key thing that we see time and time again, many of these studies tend to be observational in nature, and therefore there's always that risk of confounding. And still the absolute risk increase overall remains very, very low. So overall, it's unclear how much of that association is causal in nature versus due to the effects of confounding. And then we're on to our third case. And so this was a 25-year-old G2P1 at 15 weeks gestational age with a 17 on the EPDS who had a history of bipolar disorder, several psychiatric hospitalizations, was recently on an inpatient psychiatric unit, and she was started on lamotrigine and discharged without any outpatient psychiatry follow-up and has no one to prescribe her psychiatric medication. So the OB provider calls us and says, I'm really worried about this patient and I'd like her to see a psychiatrist. Can you help? So additional history includes that the patient has been on several psychiatric medications in the past, is not currently suicidal, and has had therapy previously, but does not have a therapist currently. And so what we discussed is we talked about the signs and symptoms of bipolar disorder, including hypomania, mania, florid psychosis. We talked about MCPAP for moms, how it works. We discussed the evidence base of lamotrigine, therapeutic drug monitoring, how to do it. We discussed that we don't prescribe the lamotrigine, but she could always call back at any point with more questions on how to actually titrate the medication, the risk of Stevens-Johnson syndrome and the rash. And the OB was comfortable with doing that. And in terms of resource and referral, our team helped the patient find a psychiatric prescriber and therapist, followed up with the patient a month later to make sure that those resources were set. And the OB was happy to bridge lamotrigine short-term only during that time period, which I think is absolutely appropriate. Bipolar disorder is a complicated illness and requires the help of a psychiatric prescriber. But oftentimes we find that OBs and other frontline providers are happy to prescribe meds like lamotrigine if they have our help during the process, and if our resource and referral team can help them find a psychiatric prescriber for the long term. So that's what happened here, and the provider was happy to prescribe lamotrigine after the phone consultation with our help. Next slide. So bipolar disorder is particularly common during the perinatal time period as compared to other time periods. And this is, again, Catherine Weisner's JAMA Psychiatry 2013 study. And so the reason this is an important study that we often cite is because this was the largest scale depression screening of postpartum women, and the first time a full psychiatric assessment had ever been done in a study of postpartum women to date who had screened positive for depression. And the study, which included a depression screening of over 10,000 women who had recently delivered, it really revealed a large percentage of women who suffered from recurrent episodes of major depression. And what the study found was that the most common primary diagnoses were unipolar depressive disorder of 69% that you see in that blue, and almost 2/3 had comorbid anxiety disorders of that blue. And of the women who had screened positive for major depression, 23% actually had bipolar disorder. and the majority of who had never been diagnosed by a psychiatrist or a physician ever before. So I think the key thing from this study and this slide is that clinicians really need to know that the most common clinical presentation in the post-birth period, it's really much more complex than a single episode of depression. And the depression is often recurrent. 2/3 of the time, it's superimposed in anxiety. And we also have to think about bipolar disorder because 23% of the time, it's secondary to a bipolar spectrum illness, not unipolar. And that dictates the treatment. There's often a delay, I notice, and I think correctly diagnosing bipolar disorder. And a lot of it has to do with identifying not only that depressed, that low phase, but also the high phases, the manic and hypomanic phases as well. And really to accurately capture that full, the full spectrum of illness, you need a lot of collateral information and longitudinal information, and that can take a long time. But for this study, the 23%, that was a very high rate of bipolar disorder that had ever been seen in a population screen for postpartum depression ever before. And it's significant because antidepressant drug treatment alone can worsen the course of bipolar disorder. And so that's why the AIM perinatal mental health bundles and ACOG, they really drive home that even with if you suspect depression, we want to offer the EPDS, a validated screening instrument for depression, anxiety, and an MDQ for bipolar disorder or an RMS that I'll get to in a second. Next slide, please. So bipolar disorder in pregnancy is associated with negative outcomes. We know that pregnancy does not in itself protect against mood episodes. Bipolar disorder, like depression, is associated with low birth weight, preterm birth less than 37 weeks, SGA, small for gestational age, increased rate of C-section, and mood elevation can lead to behaviors with known perinatal risk. For example, substance use, high-risk driving, hypersexuality. So anyone who comes in touch with someone experiencing a relapse or in the manic or depressive phase is impacted. So that's why it's so important to connect individuals at high risk to mental health care providers as early as possible, even in the preconception phase if possible. Next slide, please. Bipolar disorder increases the risk of postpartum psychosis. Postpartum psychosis is rare. It's 1 to 2 individuals for every 1,000. So it's rare, but potentially very lethal. Greater than 70% of the time, we know it occurs in the context of bipolar disorder. The highest risk clinical window is really 24 hours to 3 weeks postpartum. Can you see it after that? Absolutely. In some of my clinics, I can see it weeks to months after, especially if the baby is going through a sleep regression or a toddler is going through a sleep regression and the parents are just really struggling. That can happen, but for the most part, it's really immediately after birth. So that's when we're on lookout for that. Mood symptoms, psychotic symptoms, and disorientation. We really want to rule out medical causes of delirium. And this presents like very much a delirium-like illness because of its waxing and waning nature. It is a true psychiatric emergency. 4% risk of infanticide, 5% risk of suicide with postpartum psychosis. Most people with bipolar disorder do not go on to experience postpartum psychosis. It is very rare. But if someone is high risk and is not on treatment for bipolar disorder, this certainly increases the risk. So we want to get our patients treated as early as possible. Next slide, please. So the mood disorder questionnaire is a self-administered screen for bipolar disorder. It screens for lifetime presence of bipolar disorder. It's validated during pregnancy, sensitivity and specificity of 89% and 84%. And further clinical assessment with a perinatal psychiatrist consultant can be had. And this is where MCPAP for moms can help. We can talk to you diagnostically over the phone about this, or if in a face-to-face evaluation if we feel appropriate. And remember, it's a lifetime presence. Just want to emphasize that here in contrast to the EPDS, which is the past 7 days only. Next slide, please. The CD3 question bipolar sum is another screening option and needs to be asked the provider. This is also a quick screen that you can do, and this is on our MCPAP for Moms OB toolkit as well. Next slide, please. So the rapid mood screener, RMS, is another screening option. And this is new, but this is something that I actually prefer to do in my clinics because I think it's actually easier and quicker than the mood disorder questionnaire, and it's not in our toolkit yet, but it will be in our toolkit in January 2026 when it's posted online. And the RMS differentiates bipolar 1 disorder from major depressive disorder in patients with depressive symptoms who have been diagnosed with MDD. And the reason I like the RMS is it tends to have less false positives than the MDD, than the MDQ, and it's much shorter and it's much easier to implement, and it's easier to implement and more pragmatic, I think, for more primary care settings. That's actually a typo. It is not validated during pregnancy, but still it can be used in perinatal individuals. It has a sensitivity and specificity of 0.88 and 0.80 respectively. And like I said, compared to the MDQ, I find it's quicker and easier to implement. And we're happy to talk about this with you during consultations. Next slide, please. So this is our last case, and this is a 25-year-old G3P3 who reported symptoms of depression at the pediatrician's office. And the pediatrician calls and reports that she doesn't know the patient well because the baby is her patient, not the mother, and she calls to ask you for help. And so we absolutely get phone calls from pediatricians. So who can call MCPAP for moms? So anyone can call. We take calls from anyone. And like I had said earlier, we require a prescriber to call if discussing medications during a phone consultation or if a face-to-face evaluation needs to be done. But anyone can call and we can talk about anything related to general perinatal mental health during a consultation. So for this case, our MCPAP for Moms consultant recommended that the pediatrician asked the mom's PCP to call MCPAP for Moms for a phone consultation because the mom was looking for medications, and the pediatrician was able to do that. And we felt a phone consultation was needed to talk about medications, potential risk assessment discussion, validated screening instruments, the SWIC, potential pharmacotherapy. And so that's actually what happened. And so our RS team also found a long-term psychiatric prescriber for the patient along with a therapist, but the PCP was happy to, once the pediatrician connected with the PCP, was happy to prescribe in the short term and or long term, since it was an SSRI and they felt pretty comfortable, doing that. So that's what I'll say. When we get calls about pediatricians, if it's not about something like case 4, it can be about general, like a phone consultation I had with a pediatrician recently. They were curious about medications and relative infant dosing and RAD because the mom was breastfeeding. So we talked about that. And I know the pediatrician knew that he wasn't going to prescribe, but he was just curious. And that was an example of, a great phone consultation that we had. We can talk about risk assessments. We can talk about safety. We can talk about, a positive screening and a SWIC and what to do. But a lot of questions from pediatricians tend to be about resources. Yes, and next slide, please. So MCPAP for Moms can help provide a solution by building the capacity of perinatal care settings to provide mental health care. And we do this through 3 main mechanisms. So resources and referral, education, and perinatal psychiatry consultation, which is the phone consults, which is, for example, the 4 cases that we just went over, and one-time face-to-face evaluations with one of our consultants and your patient. And the phone consult, I would say the education, if I could overlap the second 2, I would, because the consultations really include a lot of education as well. But for example, trainings, toolkits, webinars, those are all examples of education that we can also offer. Next slide, please. So since our launch in July 2014, MCPAP for Moms has served many clinicians and parents, and we have really enjoyed, being on this ride with you all and helping build the capacity to our perinatal care professionals across the state. We serve on average 300 to 400 individuals per month. So we've enrolled about 85% of the obstetric practices in the state of Massachusetts to date. Of those enrolled practices, a little more than half are utilizing us, and we've served total distinct 22,000 perinatal individuals. And I'll just emphasize the face-to-face evaluations we can do them. They're a great way to provide education to the patient and the prescriber, and we've done over 1,000 of them to date now. Next slide, please. So who can call MCPAP for moms? Anyone can call. And while we only enroll OB practices, and that's just for, data tracking purposes, anyone can call us. And we welcome you to call with any types of questions. So obstetric providers, midwives, family medicine providers, SUD care providers, psychiatric providers, pediatrics, and primary care providers, anyone interfacing with a perinatal care individual. And patient consultations are generally it can be done with anyone, but like I had said, a medication related consultation about medications prescribing, we encourage to be done only with prescribers. We only take calls from prescribers. Next slide, please. So providers can call 855-MOM-MCPAP for consultation for mental health and SUD topics. So you would call 855-MCPAP, you'll either get someone live or you'll leave the demographics, your demographics and patient info, clinical info in a HIPAA protected voicemail. A resource and referral specialist will extract all that information. If the request is for resources to provider, those are usually just sent straight to the provider, depending on the information that was put in that voicemail. So I would just add here, if you want it emailed it to you, if you want it faxed, if you want something else, please specify in that voicemail how you want it sent to you. And we encourage for prescribers, especially if there's a potential face-to-face needed or a medication related question or a phone consultation, a cell phone number, a really fast way to get through to a provider so we can find those providers quickly to do the phone consultation. So we can do resources to provider, and then we do we can do the provider to provider phone consultation, which results in a potential face-to-face evaluation with our consultant and your patient, or resources to patient, which is what we abbreviate as patient contact. For all patient contact, we always request a phone consultation. Next slide, please. So what we have found is that the consultation really is the engine of MCPAP for moms. And that's because in our consultations, we can discuss potential management strategies, recommend a face-to-face evaluation, refer to the community. We've had about 25,000 encounters to date. And we find that the data also shows the consultation is really the most effective part of MCPAP for moms of the program. And the most effective part is actually the face-to-face evaluation. And I think that makes sense because that's where we really get into the diagnostic evaluation, talk about validated screening instruments, talk about medications, and provide that education to not just the patient, but also the prescriber, and we talk about resources. So that's probably the most comprehensive component that we can offer, and that's the most effective according to the data that we've internally done. Next slide, please. So resource and referral is based on acuity, severity, and need. So when we talk about resources to provider versus outreach to patient, so a resource and referral specialist really identify 2 to 3 targeted resources and share in a list form with the providers. This does not involve speaking with the perinatal individual. And we talk about outreach to the patient. Resource or referral specialists will connect to the perinatal individual and work with them to schedule the appointment. They will also follow up with that patient a month later just to make sure that the appointment was scheduled, to get feedback, and to really just make sure they're supported during that process. We will usually outreach 3 times until we get a hold of someone before we close out the case. Sometimes it may be hard to get a hold of patients if they don't pick up, but we always outreach 3 times for our outreaches before we close out that case. And we will include the Massachusetts Behavioral Health Helpline in our resources, the Maternal Mental Health Hotline, local crisis numbers, PSI, really anything and everything, or we can tailor it specifically to something the patient is looking for, a specific interpreter, a specific type of psychotherapy. So they're really tailored resources. And we have a fantastic large group of resource and referral specialists who handle that, and that's their job, and they really enjoy doing that and interfacing with their providers and patients. Next slide, please. So our number is 666-6272. We're open Monday to Friday, 9 to 5. Our trainings and toolkits are on our website, and we provide real-time provider-to-provider phone consultations and resource and referral, like I mentioned. And the next slide goes into our SUG program I want to briefly talk about before we get to questions. MCPAP for Moms aims to promote maternal and child health by building the capacity of frontline providers to address perinatal mental illness and SUD concerns. And SUD. So the next slide, MCPAP for Moms, so toolkit and EL modules are available to provide for obstetric clinicians through ACOG. So our MCPAP for Moms obstetric provider toolkit is on our website, and a more comprehensive and high-level expansion of that is the Lifeline for Moms toolkit, perinatal mental health toolkit. ACOG actually owns that now, so that's on ACOG's website, and that's on the Lifeline for Moms website. So those are two toolkits that, you know, they were grant funded. A lot of work was put into them, and they're great resources for you all. We also have the e-modules, and the e-modules I think of as just a very high level interactive asynchronous crash course you could at any point on your own time, and that's on acog.org mental health. That was funded by a grant from the NIMH. And I would encourage you all to look at that. It's free, and it really just goes through a lot of like cases that I had gone through and goes through the bread and butter of perinatal mental health. And it's short. You can do it really in just 1 or 2 hours. It goes by pretty fast. And that's one of that's on ACOG's website as well. Next slide, please. So the SUG treatment provider toolkit. So MCPAP for Moms has an SUG program that's dedicated to SUG concerns in the perinatal setting. And you can always call the MCPAP for Moms line, inquire about the program, and our SUG program manager will get to you. So it was finished in 2021. It's being updated right now, and the newest version will be put up January 2026 on the website. It talks about SUG in the first half of the toolkit, followed by 3 fact sheets that discusses non-stigmatizing language, trauma-informed care, reproductive life planning in the SUG setting, and the second half focuses on SUG concerns, and it also goes into psychopharm and MOUD. So a lot of good resources there for you all as well. Okay, and I think we're nearing the end. And these are vetted resources that we have for you all that we love to share with our providers, our trainees, and you know, sometimes even our patients will ask for them. So we recommend this list. Great. And I see a question in the chat. Let me just bring it up. Can you comment on maternal SSRI use in the development of autism spectrum disorder in the child? Yes. So I will say that there have been a number of recent studies, high quality studies, which will actually control for confounding factors such as maternal depression, which is something that we're always looking for, you know, were there confounding factors controlled for, as well as genetics and environment, and they have not shown any evidence of a causal relationship between maternal SSRI use in utero and autism spectrum disorder in the developing child. So that's what the data says. That's, you know, from pretty rigorous studies. So that I would say that's the answer. The baseline risk in general of autism spectrum disorder in the general population, it's about 1 to 2%. And if an SSRI is used during pregnancy, the risk may appear to rise to about 2 to 3%. It does increase, but I think the key thing is after adjusting for confounders, that difference is not statistically significant. So I think that's the big thing that we have to remember. After you adjust for confounders, there is no evidence of a causal relationship between the two. So even if a small risk exists, it is so tiny. And the key thing is it is much smaller than the risks of untreated maternal depression. This goes back to that risk discussion that I was talking about earlier. So there are much, you know, there are other risks of untreated maternal depression that we have to look out for. It's a great question. Thank you for asking. Are there any other questions? Yes, and that's, so I actually have 2 questions on text. So Do you want to, so can you briefly tell me about early childhood and how that's different from your program? MCPAP Early Childhood was started about 4 to 5 years ago, and that addresses the 0 to 2 year old age group. And MCPAP Early is a great resource. They have child and adolescent psychiatrists who can talk to you about diagnosis specific to, great, I'm glad you found that helpful, specific to that age group. And MCPAP for Moms, we will also, if we feel like it's appropriate, if we're doing a face-to-face evaluation with a patient and or a phone consultation, if we feel like the perinatal individual, the mom, may benefit from a MCPAP for Moms early childhood, after obtaining their consent, we can send the information for the program to the baby's pediatrician, and the baby's pediatrician can then put in that consultation. But it's a wonderful newer program, and we encourage you all to, look into it and think about it for that younger age group. And then I actually have someone who was asking about I think it was case number 2, and stopping antidepressants during pregnancy, and what that actually looks like, and the numbers I had mentioned. So I think deciding to continue or stop antidepressant medication during pregnancy, it's a personal choice, but it has to be had, collaboratively with your prescriber. And so most perinatal individuals stop antidepressant use during pregnancy for various reasons, and recent studies indicate that about 75% of individuals who take antidepressants during pregnancy, in the year before pregnancy, will actually stop it during pregnancy. And studies will also show that for patients who experience moderate to severe recurrent depression, stopping antidepressants during pregnancy brings a high risk of depression relapse. There was one study that actually found that patients, and I think this is the one that was cited after this, who stopped antidepressants were 5 times as likely to experience depression during pregnancy when compared to women who continued it during pregnancy. So I think that was at 65% slide. The risk of relapse, I'll just add, it's really high, especially in the first 3 months of pregnancy. So even for women who stay on their medication can have a relapse, but the risk is much, much lower. I think that's key. It's like around 20 to 30%. So it's much lower. So that's what I'll say about that. Okay, any other questions? Don't see anything in the chat. I will put my email address. If anyone has any questions at all, please don't hesitate to email me or call, or Beth, if you could put the MCPAP email as well, that would be great. And thank you all for coming. Made it just in time. Hope this was helpful.
And just a reminder, please be sure to complete the brief survey that's going to be coming your way. And again, a reminder that the PowerPoint and the materials from the tape of this session will be on the website as well. So thank you very much for joining us today. And thanks,
everyone.
Dr. Hayter. Okay, bye-bye.
All right, bye.